In this video, we're going to talk about some joint disorders or conditions. And there's two joints that really stick out in my mind as being vulnerable to dislocation. One of them is the patella. So you can see here, the patella should be right there in the trochlear groove of the femur, and it's dislocated laterally, and this is the direction it typically goes. There's a ligament over here called the lateral retinaculum that's pulling. If someone's vastus medialis obliquus, one of their quadriceps, is weak, it has attachments to the kneecap, it might allow it to ride laterally. Females, especially with a higher Q angle, so their hip to knee is a large angle, then that could put more stress on the patella to move laterally. If some of their hip muscles are weak, that can contribute to it, especially hip external rotators. We hear the rotator cuff of the shoulder. It's kind of the muscles that rotate the hip that can really help align everything so the patella stays in place. But I've reduced these before, and you just kind of flex the knee up and the hip, and as you extend their leg, you just push medially and it'll just kind of clunk back into place. But this can tear tissues on the inside, specifically the medial patellar ligament. And if that happens, an orthopedic surgeon will then have to perform a medial patellofemoral ligament surgery, MPFL for short. This is where they'll typically use an autograft, so a tissue from the patient. A lot of times it's a hamstring, the tensor fascia lata, quadriceps, or occasionally allograft. That would be from a cadaver. So auto means self, autograft. Allograft would be a cadaver graft typically. And what they do is they'll drill holes on the medial aspect of the femoral condyle, medial femoral condyle, as well as the medial aspect of the patella. And they'll just kind of thread that tendon in and hold it medially to keep it from dislocating again. And sometimes people will have recurrent dislocations, and subluxation is where the patella in this case would shift laterally, but you could kind of wiggle your leg and it'd pop back in, or it may just go back in on its own. That's a subluxation. Whereas a dislocation is where it goes out, stays out, and requires someone to reduce it back into place. The other most common one that sticks out to me is the anterior dislocation of the shoulder. Here you can see Kevin Love. Obviously the head of the humerus is way down here instead of in the glenoid up there in the socket. And this can tear all kinds of tissues too, usually the labrum, which we'll see on the next slide. So with the ball and socket joint of the shoulder, you have the head of the humerus and you have the glenoid of the scapula. And the glenoid, it's a lot smaller than the head of the humerus. So you need this fibrocartilage called the labrum to help deepen that socket and keep the head of the humerus from dislocating. But if there's a lot of stress, the weakest area of the shoulder is the anterior front side, and that head of the humerus can slip out the front, and many times it can cause a tear in that glenoid labrum. And that will require surgery to stitch it up, and it's a long rehab process. Typically, they're about 6 to 8 months from returning to their sport. This is one you see in baseball players a lot, especially pitchers, where they're putting all that torque on the medial elbow, so the inside elbow, and it can tear the ulnar collateral ligament. So you have the humerus, the distal humerus coming down, and you have the radius over here, you have the ulna on this side, and so this is the ulnar collateral ligament that is on the inside of the joint. If it tears like it does in this picture, they'll have to do an ulnar collateral ligament repair. The orthopedic surgeon will do this. It's also known as the Tommy John surgery. And a lot of times they'll use a muscle that's in the forearm called the palmaris longus, because it's kind of an extra tendon that's maybe a vestige from when we used to climb trees from an evolutionary standpoint. If a few people don't have this, maybe I think it's about 14 or 15% of the population don't have that, and I've seen patients that have had it taken from their hamstring and use that as an autograft to rebuild the ulnar collateral ligament. So these are a lot of sports injuries, and that's what I work in, as sports medicine. So see these day in and day out. This is actually a video of one of my patients tearing their ACL, and there's a valgus stress in this one where she goes up. She's on this side, so watch over here. She's going to go up to hit the ball, and when she comes down, she lands on one leg, and her hip muscles are too weak to withstand her knee going in. And you can see how her knee will go in and collapse. And let me see if they'll even let me do this. Yeah, here we go. So watch over there on the left side. She goes up, hits, and it goes in. It's going to show slow motion here. You can tell it buckles the knee in, and she had the terrible triad, which is a tear of the ACL, the medial meniscus, and the MCL. So when you tear your ACL, you can see a full thickness tear right there in the middle. Here's a lateral view of an MRI, and you can see that the ACL is outlined, and there's definitely a breach between the ends right here. So to return to a sport, you're going to have an ACL reconstruction. And in the previous video, we saw the unholy triad, and sorry for the clicking, trying to get that to show up. Most ACL tears are non-contact, so someone may cut funny. I've actually torn my ACL, and it was a situation where I was trying to cut back, and my foot kind of stuck in the ground, and my weight shifted. And you always have this tear. It's a pop, but you can feel it tear, and it's something most people remember that have had this injury. You can also have it through hyperextension. I've had several athletes that someone would fall on their leg and their knee would kind of bend the wrong way, hyperextend, and it can tear the ACL as well. So there's 3 different types of graft that an orthopedic surgeon typically uses to repair the ACL, reconstruct it. One is the hamstring, which is the semitendinosus muscle. Sometimes they'll use some of the gracilis as well. That's on the inside. If you feel behind your knee, you can feel tendons on the inside, the medial side, and on the lateral side. These are the ones that are more on the medial side. And then you can also do the middle third of the patellar tendon. So here's the patella, and it inserts into the tibial tuberosity of the tibia, and the orthopedic surgeon will cut out this bony plug. I worked for Aurora, where we would go in after someone passed away, and we would take all these tissues out for allografts. So I would take the gracilis and semitendinosus, as well as the middle third of the patellar tendon. I'd always make sure to get bone off the patella and bone off the tibia, because these grafts, they're bone to bone, and when you have bone on both sides, it really helps and make a solid graft. Whereas the hamstring, you only get one bony side from this side, but this one you don't. And so the orthopedic surgeon will just drill a tunnel through the lateral femoral condyle and the medial tibial condyle and just thread that new graft through. And cruciate means cross. You can see the ACL is anterior, and then the PCL is posterior. Anterior cruciate ligament, posterior cruciate ligament. With 60% of ACL tears, you'll get a meniscal tear as well, or sometimes you can just get a meniscal tear by itself. But the meniscus is a C-shaped fibrocartilage, so this would be like maybe the medial side, and then you'd have another C shape over here, or backwards C for the lateral side. And you get better blood supply on the outside, so if someone tears the meniscus on the periphery, sometimes they can stitch it up and get a meniscal repair and save that cartilage. But if they tear it down here deeper, they'll just debride it. And it's called a meniscectomy, where they go in and smooth out the frayed, torn meniscus. But you're going to lose some meniscus, which causes bone on bone sooner. And a lot of people have arthritis after this surgery down the road. So with a meniscal repair, they use sutures and they stitch up the meniscus a lot. And this will take you. My patients will usually be about 6 weeks on crutches in this situation, because you don't want to get any compressive forces through there so that meniscus can heal. But if it's a meniscectomy where they just shave it out, they can just walk whenever they can, from a pain standpoint. So this meniscus should, if it was healthy, it would have extended all the way through, but it's been debrided so that it won't be loose and floating around in the joint.